Thank you. Thank you for that kind introduction. Today I'm going to talk about, and thanks Jeff for inviting me, and this is a passion of mine. So I want to just take you through how we in South Africa started to develop a national strategy to do fertility preservation, and then to see how this is played out in our clinical practice. Let's go to the next slide. Down. Okay. I just want to raise your attention to this slide, what Thomas Edison has said. And this is all about training ourselves in a certain speciality. And if you do train yourself, you might come about opportunities where you can actually make a difference in patients' life. And I'll come back to the slide again in a later. So the question is, why fertility preservation? Well, basically twofold. The oncologists got better, their treatment got better, and we've been starting to see younger patients now going through survivorship. And the question is always, what is the contralateral, the cost to their fertility treatment? And obviously one of these things will always be their fertility. We as reproductive specialists has also got better in freezing eggs and sperm and embryos, as well as recently ovarian tissue as well. So the question was always, how do we combine these two worlds? Where can we meet? So the first time I've heard the word oncofertility was during an overseas conference, and the word was just so intriguing to me as well. So to have oncology, which is quite morbid, versus fertility, which represents new life. And coming back, I said to the guys on the SASREC board is, listen, we need to take this forward. How can we all contribute to making this a standard product? We all have different fertility clinics. It's all scattered around the country. But the question is, how can we address all of this at once? And starting to make sure we're knowing what each other are doing. So I've identified these following 5 points, and I think that became very important when you start setting up a national network. First of it was to say, what services do we have available? What is our data currently? How do we get our oncology partners on board? And again, looking at raising awareness amongst our public and our advocacy groups out there. Very importantly, how do we assess ourselves? How do we improve this product that we want to offer to the patients? And lastly, like Dr. Gerald has said, the difficult topic always about funding. So just looking at the evolution of cryopreservation, we know the first recorded pregnancy from cryopreserved sperm was recorded in 1953. Move 30 years onwards, embryo cryopreservation, the first pregnancy from a frozen embryo was recorded in 1984. And then it had to take almost 30 years again before we were able to start freezing oocytes effectively. Yes, in 1999 we did freeze embryos, oocytes, but it was not that effective. So with the advent of rapid vitrification, we were now able to freeze oocytes in women that's not committed in a relationship, and to say we can do it effectively as well. And then talking about an 80% cryo survival rate in these patients. The problem was also, what did we do for our prepubertal patients? Our younger patients who have not entered puberty and they are about to receive cancer treatment. And again, after 250 recorded published cases of live pregnancies from ovarian tissue cryopreservation, the experimental status of ovarian tissue cryopreservation have now been lifted. And this is also very important to say, this is now something we can start offering our young females. Now, to complete that full circle is still testicular tissue cryopreservation, and currently we are doing that, but under experimental sort of guidelines. The first recorded pregnancy was recorded in the rhesus monkey about 2 years ago, and we're eagerly awaiting, there's a lot of research in this going, but we don't think it's very far when the first pregnancy will be recorded from testicular tissue cryopreservation with reimplantation. So these are the services that was and that is available. The question is, where do we also start? Do we start reinventing the wheel, or do we approach the international guys that has gone through this as well? And this is how we linked up with the Oncofertility Consortium based in Chicago. But interestingly enough, in 2017, there was no flag in Africa, the whole of Africa. It was just quite interesting. I was lying in bed and I was just showing my wife and say, shoo, we in Africa need to start catching up what the rest of the world were doing. So the first flag was planted there in 2017 in Johannesburg, and I've encouraged some of our other units in South Africa as well to join this consortium. And again, oncology cases is not easy cases. Each case is different, so you need to align yourself with people that are experts in how they manage previous cases like this as well. And this again is the invitation. There is no pin drop in Zimbabwe, so and I think this is very important for this talk as well. I hope we can get some discussions going, how we can get some of these units linked up with the Oncofertility Consortium. So going through the next challenge was how do we get, looking at the data, sorry. So we know we have, in South Africa, we have a national cancer registry, so we know how many patients are being seen and treated during the reproductive years for cancer treatment. The question is how much of our fertility preservation procedures is being done. And again, looking at 2018, in South Africa, being part of the African continent as well, there is the ANARA registry, Silke Dyer from UCT as well. She's leading this project, where all artificial cycles or reproductive techniques are recorded in this cycle. So just looking at 2018, we know, but this was the baseline, that less than 1% of the patients who get cancer therapy of reproductive age got fertility preservation options. So that was it. There was a lot of work to do. Again, and that's just what that slide sort of stipulates. The next challenge is getting the oncologists on board. And again, oncologists, like we all know oncologists, they are very protective of their patients with all rights. These are very, very sensitive cases. There's a lot of psychology involved here as well. And how do we get them on board to trust us to say, can you give your patients so we can assist them helping to preserve their fertility and not interfering with their sort of daily activities as well. So we've been fortunate enough over the years that we have been invited to these societies, to their national conferences, where we can start spreading the word of oncofertility. And again, just showing them that we have been educated in this as well, and it's not going to interfere with the outcome or the prognosis of their patients. And this is just aligning it, our medical oncologists, our breast cancer surgeon society, our gynecological oncology society, and as well as the stem cell transfer society. So we are all endorsed by them again, but then again, that raises the next point is we need to up our game. Very importantly, out there to the general public is just to involve your patient advocacy groups, advocating these cases. Again, oncology buddies, they usually would publish some of these very good stories of how these survivors have started with their families and have moved on with life. So going to doing some self-reflection. In South Africa, according to our SASREC, there's 20 clinics that's been SASREC accredited, so they comply with certain standards. Again, as part of these standards, if you want to do oncofertility in your clinic, you need to comply with these recommended operational practices. And there is an inspection that will come, and then usually you need to present your data to say, well, if I freeze eggs, this is my survival rate of oocyte freezing. And what is also important for our patients with oncology patients, it's different than fertility treatment, because fertility treatment you might have different, or you might have multiple attempts. Hopefully not, but you might have. Oncology is you're going to freeze those eggs once before the chemotherapy starts. And once it starts, that's that patient's only chance. So you need to make sure you give hope, but not false hope. And again, just going through the challenges of funding. And this also became very important when we were able to show that the medical aids, that this is our way of evaluating ourselves and having an accreditation process. It actually got 2 medical aids on board to say, well, they were now considering funding for oncofertility. And again, we can always just continue approaching these medical aid funders to say, can we get you on board and assist our patients? Like we know in South Africa, 50% of our patients is is from the private healthcare, 85% from the public healthcare. So we also are facing with a lot of challenges there. Question would be, after we've implemented this, I went to look at our data in our clinic and to say, how did it impact, starting to spread the word out there. And this is just to show you, as from 2015, how the numbers increased to our clinic. This is what our female oncology patients, there was a spike there, but that was just the post-COVID years where people did not go for routine checkups, and they, and then the next following up year, they were diagnosed with breast cancer and they were sent to our clinic. But that is quite encouraging just to see, to try and increase the numbers, getting the word out there. Unfortunately, in our males, we also saw a steep rise, but then there was a drop-off as well, and that maybe just said to the point we need to start focusing on our urology colleagues. So this is how we sort of got to a structure and how do we approach our patients. I quickly just want to run through 4 clinical cases, just to make it a bit interesting. I will see how we get through it with our time. First case is about a 27-year-old with a positive breast cancer patient. This next one is a 32-year-old patient who's been diagnosed, which we see in our general gynecological practice as well, for low egg reserve. The third one was an 8-year-old that presented with acute lymphoblastic leukemia. And the last one was a 70-year-old male, 27-year-old male with testicular cancer. So first case study, it was a 36-year-old nulliparous patient, like I said, referred with estrogen-positive breast cancer. The treatment proposed was a bilateral mastectomy with no dissection and adjuvant chemotherapy. Now, if I approach our oncology patients that's been referred to us, I always go through these next 5 points. The first of all, what is their current fertility status? How do we measure that, and is there anything to be preserved? If she's 44, well, then we've passed, we missed that bus. Looking at what the gonadotoxic risk is of the chemo regime that is being proposed, and again, what effect that will have on her current fertility status. And again, will our treatment not lead to disease progression as well? And I think that's always important, that you're not going to interfere with the oncologist's sort of treatment plan. So we know the best biomarker for assessing your current fertility status is your AMH, and the other one would be your antral follicle count. And then usually plotting these patients according to that graph published by the ASRM. So in this patient, quickly want to say something on the slide as well, that AMH is not a reflection of your chances to fall pregnant, but it is a very good reflection of your reproductive lifespan. And obviously after treatment it will fall and then ultimately shorten that patient's chances or years to conceive. So in this specific patient, the AMH was 0.8 nanograms per deciliter with an antral follicle count of 5. So it was well below the median. So she was at high risk of losing her fertility after treatment. The next thing is looking at the chemo regime, and I think this is also very important to know, is what is being prescribed to this patient, and knowing that this as well. There's been multiple publications to say as what risk the treatment holds, and in this specific patient, she had a 50% of lowering her anti-Müllerian hormone count, or her fertility count. Now, important, and this is very an important slide, is when you look at this as well, what happened when someone gets chemotherapy? So usually you will see this patient, she's got a good egg reserve, this one's got a median, and this one's got a low egg reserve. So this is exactly where our patient is. So after chemotherapy, then for 18 months to 2 years, that AMH will drop. And then after 2 years, there might be a slight rise, especially in the women with a high reserve or medium reserve. But in the low reserve, that rise will never take place. And then this is the group of patients you want to be focused on to make sure that you try and preserve their fertility. Again, in this patient, we did random start stimulation, so it's not cycle-related. As soon as you see the patient, you start stimulation. Doesn't matter where she is in the cycle. We've got 15 eggs, 9 of these eggs fertilized. We got 2 blastocysts out. We did biopsy it, because we wanted to check for the BRCA gene within the embryo as well. Unfortunately, both embryos came back genetically normal. Fast forward 3 years later, the oncologist agreed to a fertility break for this patient. We looked at the egg reserve. It was now undetectable, and she was in a menopausal status. So we stopped the hormone blockers, and we did a medicated embryo transfer cycle for her. Unfortunately, she conceived and delivered a healthy boy. Case study 2 was a 34-year-old, and these are patients we see a lot in our general gynecological practice. So she just presented for a routine checkup, and the doctor was well aware of her fertility and said that she had a low AMH of 0.7 for 34 years of age. That is well below the median there, and advised her to go for fertility preservation. She was single, so obviously we were looking at oocyte cryopreservation. And the question will always be, once you freeze these eggs, the patient will ask, doctor, but what's the quality of my eggs, and how many eggs do we need to freeze? And again, I'm just referring to this very good publication of the Cobo et al. Group. It's a Spanish group of patients, but a Spanish group of fertility doctors that have sort of worked it out that age and your number of eggs will relate to your chances of conceiving after you've stored your eggs. And again, this graph actually shows that the more eggs you have, the younger you are, the better chances you have to conceive with those eggs. To this specific patient, the first cycle we stimulated, we got 4 eggs, and that actually related to about a 5% chance of a cumulative live birth rate. We stimulated her again, we got 2 eggs, not a great cycle, and that took us up to about 50% chance of one day achieving a cumulative live birth rate. And in a third cycle, we stimulated her, we got 12 eggs, and now we were sitting with about 18 eggs that we vitrified for this female. Fast forward 5 years later, she met her husband. He fortunately had a very good sperm count. Her AMH was 0.3, and she had irregular menstrual cycles then. We went to fertilize these 18 eggs. We transferred 2 embryos fresh, and the other 2 embryos we did genetic testing on. And she also fortunately conceived with a healthy and delivered a healthy boy as well. So this is all about what I said about planning and creating those opportunities. In the third patient, this was for one prepubertal patient we were approached with. She was 8 years of age, and these patients are acutely sick when they present. So first of all, the way they will be managed, they get induction chemo, putting them in remission, and then they are being worked up for a myeloablative chemotherapy as well. Now, myeloablative chemotherapy will destroy all your primordial follicles, so it will make these girls infertile. So she was referred for ovarian tissue cryopreservation, and again, just reiterating, the experimental status has been lifted. And just as a reminder, where is all your eggs sitting? Where is your antral or your primordial follicle sitting? It's just below your capsule in that first 1 to 2 millimeters of your ovarian cortex. And again, we took one ovary of this little girl and we froze it. We got these cortical strips. And I always ask the histopathologist always to do a primordial follicle count for me. And you can see this tissue is loaded with young eggs. But then again, we'll wait until she's 25 or when she wants to start with family before we'll go and we will go in and transplant some of those cortical tissue. One thing you know, once we have transplanted this, it will take up to 3 to 6 months before this tissue becomes active and then start producing hormone as well as she will start to ovulate. Question then is it effective? Sorry, I just want to take you to, this is a patient I did last month where she had lymphoma and she was now in menopause, and we now just started to reimplant some of her ovarian tissue. So we make a small peritoneal window there where we remove the ovary, we cover it with Surgicel, and in the opposite ovary we'll just put 1 or 2 cortical strips just below the surface of that ovary as well. Question is it effective? And again, I'm referring you to this publication done by also a Spanish group, and they looked at comparing ovarian tissue cryopreservation to ovarian oocyte cryopreservation, and they found similar pregnancy rates there as well. with the only advantage in the ovarian tissue cryopreservation that 15% achieved a spontaneous pregnancy without performing IVF. Thanks. So this brings us to our last case study, and again, not to forget about the males. And again, referring to that first slide of ours as well, if you do some preparation and you do some advocacy out there as well, some of these you'll be faced sometimes with some of these good stories. So it was late on a Friday afternoon, we got I think it was the last call of the clinic coming through from this desperate 27-year-old male to say, so on the Monday morning, he's first on the list, on the urology list, he's got a testicular cancer in his right testis. Now, as a young boy, his one testis was removed with embryological testis, so this was his only last testis that was now going to be removed. I said to him, well, I'll phone the urologist and I'll ask him if we can maybe just have the testis before they send it off to the pathologist. So he agreed to that. And again, this was the testis. So I sent our embryologist to go and get it, but you can just see the tumor there almost taking up about 80% of that whole testis. It took about 3 embryologists there to get a few sperm, and we froze 5 vials of twitching or slightly motile sperm. So early this year, he got married. Fortunately, got a young wife with a very high egg reserve. And so we stimulated her, and I think in March this year, we got 35 eggs from her. She had a very good response. The question is, will we get 35 sperm from those samples? And we did. We fertilized, we got 9 embryos. And of the 9 embryos, 5 were genetically normal. They're still a young married couple, so they want to just have 1 or 2 years for themselves. But we are planning to do a transfer then in 2025. So, to conclude, I just want to say, oncofertility is a multidisciplinary approach. So you need to get all the role players to work with you as well. And you need to show them as well that you will take care of their patients. I always say that oncofertility, altruism plays the biggest role almost in all of this as well. This is not a time to profiteer. So the way we would see our patients, and I know our IVF cycles are expensive, but when we look at our oncology patients, we offer them almost baseline cost to say this is not the time for profiteering, we are just there to preserve. We can later in future, when you have time, we can then start looking at IVF. And also to try and include everyone, so to make this also available in our public sectors as well. And we know some of these are expensive treatments, but also to share that knowledge as well. And importantly, like I said before, is we know that fertility preservation plays a big role in the psyche of a patient who's just been diagnosed with cancer. It gives hope to these patients, and it transcends them to the future as well. So no, this is very important to make sure that we give them the best chance of achieving a biological child. But what is also important then is to make sure that you understand there's never a guarantee of a pregnancy, but at least it is a good attempt of trying to have that biological child. So I want to thank the organizing committee, Jeff, especially you, for inviting me. When I got the invitation, I always thought I always look for a reason to be in Zim. It was 30 years back that I was here in Bulawayo. I usually go up to Falls. But yeah, you've stirred my appetite. So next time I bring my wife and go to this lovely country of yours. And what I thought about last night as well, it's the pristine beauty of this country is amazing. But I think your biggest asset is your people, the friendliness you see. And I've worked with many Zimbabweans in England for 3 years. Very, very friendly people. So keep up doing what you're doing, and I hope we can contribute to your journey as well.